All right. So it's 12 o'clock. I'm going to launch things quickly today so we have enough time to get questions in and so forth. So welcome to the Lyda Hill Institute for Human Resilience seminar series. I'm going to let Brooks go ahead and introduce our speaker today. But I just want everybody to know who's on the Zoom call today that we will have a early fall seminar coming up as well, and we'll be putting out information about that as soon as it's possible when we get a date nailed down and a speaker set up for that. So that'll be coming around. Make sure you look for that information from us. We also would like it if you're not a member of our social media outlets for you to reach out to us and get connected to us either through Twitter or Facebook or whatever. We do all of them. And we can get you connected to that. So Brooks, you want to take it from there?
Yes, and I just want to add to something Chip said. Actually, in September, in lieu of this seminar, we're going to have a pretty special symposium, and I'm going to let Heather Littleton describe that a little bit at the very end after Brandon's talk. But today we're really excited to have Brandon Griffin here. Brandon is an assistant professor at the University of Arkansas for Medical Sciences in the Department of Psychiatry and Center for Health Services Research. He's also a staff psychologist at the Central Arkansas Veterans Health System, and of course, an affiliate with our Lyda Hill Institute for Human Resilience. And his work on moral injury, which is the topic of today's seminar, has supported innovations in post-deployment mental health and suicide prevention among veterans. So thank you for being here, Brandon, and I'll let you take it off.
Absolutely. Well, thanks, Chip, Brooke, and the Institute for having me here. I really love the work that Lyda Hill has been doing and the Institute is doing. And so I'm excited to share about some of my work with you all and get your feedback on it. So our talk today will be about current directions or current findings and new directions in moral injury. The objectives that I've set is I want to describe the prevalence and outcomes of moral injury among veterans. So most of the literature here has focused on samples of military service members and veterans. But then I do want to spend some time extending the work that has been done in healthcare workers and frontline personnel, particularly during the COVID pandemic. And then the last thing I want to do is I really value the exchange among the folks who are here on the call. And so I'm excited to present a brief research agenda and some ideas about collaboration to try and foster some opportunities to work together here with the folks that are represented. So scholars' interest in moral injury is growing pretty fast. You can see here that this is a graph of PubMed articles with moral injury in the title or abstract. Count there is on the y-axis and year is on the x-axis. So in 2009 was when the real big kind of introductory paper on moral injury was published. So this is a very nascent literature. And it really didn't get going until just a couple years ago. But you can see even in the past few years that the number of articles published in the area of moral injury per year has nearly doubled, with 2020 seeing about 100 articles, which relative to the few years before is quite a jump. One of the things that I think I'm always looking for when I'm interested in a research idea is something that everybody's talking about, but there isn't much research on. And it's not just scholars that are interested in moral injury. So general public media outlets have been talking a lot about moral injury. You can see here, I have copies of New York Times article, Washington Post, BBC News, Atlantic, HuffPost, all about moral injury in veterans, and then more recently, moral injury in healthcare workers affected by the COVID-19 pandemic. So in order to understand what moral injury is, it's helpful to start thinking about what moral beliefs are. And from the perspective of psychology, we think about moral beliefs the way that we think about any belief, that these are ideas that we internalize from different sources in our environment and organize in a framework that we call a schema. So moral schemas are just like any other schema. They help us to navigate the world. And one thing that is unique about a moral schema is that oftentimes we are internalizing beliefs that come from ethical norms and standards that exist in group-based groups, organizations, societies that are all about acceptable behavior. So it's important for us as humans to belong in groups. We're social creatures. And internalizing moral beliefs that help facilitate our moral judgments can enhance our ability to survive in a environment where we need each other. And an important consideration about moral schemas is that they're not all non-conflicting, well-organized beliefs. That schemas are composed of many different internalized beliefs that are potentially overlapping and even conflicting. And so one of the ones that I like to give here is that among the veterans that I work with, they can do their job perfectly. You know, you can think about someone thinking about duty to country and the loyalty that they have to their fellow service members and wanting to provide protection while they're guarding a checkpoint and eliminating any threat that approaches. And so a person can execute that perfectly, but yet they were raised their entire life with this belief from maybe a religious or spiritual group about thou shalt not kill. Or maybe they have internalized sort of our civilian law code around murder isn't a thing that we're supposed to do. And it's not like you can check your moral beliefs at customs when you go out of the US and deploy to some other location. So many of the veterans that I'm working with are trying to navigate very complicated ethical challenges in a deployment environment while they are have little information, little time. The consequences of their decisions are great, and often there's situational constraints and moral just distress that is like emotional distress that is all kind of coming to a head when they're trying to make these difficult decisions. Schemas, moral schemas, like any schema, help us to interact with an environment. And in an environment, there are always morally relevant events that occur. So we refer to potentially, or events that could be potential transgressions of your internalized moral beliefs as potentially morally injurious events, or PMIES for short. You can kind of think about this in the terms of a stressor-related psychopathology. So with PTSD, we often refer to a criterion A event being the source of the psychopathology that follows. Moral injury as a stressor-related syndrome is similar in that. So a PMIE is analogous to a criterion A event. So this brings me to the definition of moral injury that most scholars are working from. This comes from Brett Litt's work, a 2009 paper, where he referred to moral injury as the psychological, biological, spiritual, behavioral, and social impact of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. An important caveat here is that there are a lot of different ways that a person might be exposed to a potentially morally injurious event. It helps me to think about them as either a direct or indirect exposure. So direct exposures are when we violate our moral beliefs or values by commission or omission, by something that we did or something that we failed to do. So you can think of if a child was given a weapon, if an Afghani child was given a weapon and told to approach a US checkpoint, that this is going to be a very morally relevant situation for the American service members that are told to eliminate any threat that approaches that checkpoint. And in this situation, if a service member were to fire at and harm the child, that is a commission, right? I did something that violated my values. Another situation that we commonly see in military-related events is something by omission. So MST is unfortunately very prevalent among military service members, and we'll find that oftentimes a service member may witness another service member being sexually assaulted and do nothing. or may witness the other members of their fire team using excessive violence in an interrogation against a local and do nothing. And in those cases, it is a violation of their moral values by omission because of something they failed to do. I failed to intervene to help a vulnerable person who was being harmed. And then finally, we can witness acts that transgress our deeply held beliefs. And I often find that the overlap between witnessing and omission to be pretty strong here. But we'll talk more about witnessing, especially when I get to the COVID-related part of this talk. So there is no gold standard formalized diagnostic criteria for moral injury. Here are several of the psychological, behavioral, social, and religious or spiritual putative signs of moral injury that have received the most study. This is from a review paper that I and some of my colleagues put together in 2009, but you can see the big characteristic injuries here are guilt, shame, inward anger, despair, hopelessness, people who have a foreclosed sense of a future. I don't think I deserve a good job, good relationships. I have to hide who I am if anyone's going to love me. You can see things like, in terms of social consequences, people question other people's positive evaluations of themselves. They disengage from community. So if I internalize my values from an important group, for example, my family of origin or a religious group, I am going to share those values. And when I condemn myself for violating those values, I'm going to perceive that the other people who share my values are going to reject me. Or they may actually reject me if I share about what I've done. So you can see some of the psychological and behavioral and social consequences here of moral injury. Also, for those who identify as religious or spiritual people, you can see a lot of loss of meaning or purpose. People feel abandoned or punished by whatever they consider to be sacred. They doubt their beliefs. So I thought I was a good person, but I don't think I can ever get that back. And religious deconversion. So a person who moves away from a formerly held religious belief is common among folks exposed to a potentially morally injurious event. So if you look at the bottom of this figure, you can see kind of the event-specific process of moral injury. So the PMIE is there on the far left, followed by the cognitions or attributions. So this is how that event that happens in the environment, the PMIE, interacts with my internalized set of beliefs, and what are the resulting emotional reactions, behavioral reactions, as well as coping strategies like forgiveness from self or others, how all of those fall in line in the event-specific process of moral injury, finally resulting in outcomes that can include things like difficulty meaning-making, mental health problems, functional impairment. All of that happens within a larger sociocultural context, though. And this is a point that my colleagues and I have made in a paper that's currently under review, but to suggest that there are individual, interpersonal, organizational, and societal influences that impact how that event-specific process unfolds. So you can think about gender, race, attachment, spirituality, cognitive development, even trauma history. For example, we know that people who have a history of adverse childhood events are more likely to endorse exposure to a potentially morally injurious event. And it is theorized that that is because they're more likely to identify with the victim of someone someone who's being harmed, and condemn themselves if they have not intervened. So you can see sort of that individual influence playing out on the event-specific process. Similarly, there are interpersonal interactions and even organizational and societal ones that I think are really important, that come down to feeling betrayed by an organization that one belongs to, an institution, feeling like there is a sense of group cohesion that you need to adhere to. So we know that unit cohesion is very important, but also in a threatening environment like being deployed in Afghanistan, a more cohesive unit is more likely to participate in events that violate their own values, especially if you feel like you kind of got to stay in it with everybody else so that they have your back and you have their back. And And that sort of provides an environment where moral injury is likely to occur. In addition to these influences that happen at different sociocultural levels, I think there are also outcomes that we can consider that are beyond the individual level. This is an area that is very new in moral injury, hasn't been studied a lot. But you can think of moral injury adding to cumulative stress and burnout. For example, we know that veterans are often exposed to life-threatening situations, and about somewhere between 15 and 30% are likely to, at some point in their lifetime, develop PTSD. So oftentimes you can get co-occurring moral injury and PTSD in veterans, which seems to occur about 40% of the time in the samples I have seen. Also, there are organizational outcomes related to moral injury. So this has gotten a lot of attention recently related to healthcare organizations responding to COVID. But when you have healthcare providers who are making difficult decisions, such as assigning ventilators based on prognosis due to lack of supply, and sort of making life and death decisions that prioritize organizational policies over optimizing individual patient outcomes. Those are very difficult decisions to make, and organizationally that can contribute to workplace absenteeism and turnover, low morale, and even healthcare and disability costs among employees. So just an important caveat, I've already started talking a little bit about similarities between moral injury and PTSD as both different kinds of trauma types or stressor-related syndromes. The consensus that I see emerging in the field is that moral injury follows perceived transgressive acts and elicits maladaptive self-referential emotion and behavior. So this is things like guilt and shame. PTSD, on the other hand, follows exposure to events that threaten one's physical integrity, so if they could be seriously injured or killed, and elicits maladaptive biobehavioral responses that are associated with fear. There's been some really interesting neuroscientific work looking at different regions of the brain that were activated when people were presented with morally relevant as opposed to physically threatening environments, and I think that's going to continue to grow a lot, but we're starting to see sort of different legs of the stool being put together that differentiates PTSD from moral injury based on clinical presentation, neuroscientific findings, and prognosis and treatment. Here's just a quick graphic that I think is pretty helpful from Craig Bryan's work, showing some of the overlapping characteristics of moral injury and PTSD as both stress-related symptoms, but also some of the unique components of both syndromes. So to objective one, describing the prevalence and outcomes of moral injury among veterans. I've already talked a little bit about what types of military-related events could be considered morally injurious. There are some great qualitative papers out there that help us to know what types of events our veterans might be exposed to that transgress their values. Here are two that I like coming from post 9/11 veterans in particular, both US veterans and those from the UK. And you can see that many of these involve use of violence. Many of these involve harm to a vulnerable other, and things like assaulting an elderly civilian, not being able to pull an injured child from a vehicle, failure to save another service member who burned to death, killing in war, even when it's a combatant or a civilian. So I have seen these show up in US veterans, UK veterans, a study we did with Gadi Zarak and Levi Belts and the Israeli Defense Forces. And so it seems to be kind of a cross-cutting military-related events that transgress people's values. So one of the problems that when we did that review in 2019 that we saw in the literature was that there are a ton of conceptual papers out there on moral injury, but not a lot of data. And so I am super excited to have the opportunity to share data with you today from two of the largest data sets that have been collected on post 9/11 veterans, and that include information about exposure to potentially morally injurious events and their outcomes. So this first set of studies, or this first study, is going to come from the parent study, the Veterans Metric Initiative study that the PI here is Dawn Vogt out of the Women's Health Division at National Center for PTSD in VA. But during my fellowship, Shira McGinn, and who was my director in fellowship, and I analyzed and worked with the TVMI team to try and understand gender stratified prevalence of moral injury and mental health and functional outcomes. So it's a cohort of 7,200 veterans from time 2 of the TVMI study, transitioning from civilian life assessed at 9 months post-separation. The analyses that I'm going to present to you today will be gender stratified, and they will also be weighted to the number of post 9/11 veterans that have returned. It's in excess of 4 million in the sample here. Measures include the gold standard measure of moral injury that's out there. It's the morally injurious event scale. Also, I included there are also included mental health measures for PTSD, depression, anxiety, alcohol use as common post-deployment mental health problems. And then part of Dr. Vogt's study was to develop this new measure of well-being and functioning. So we're going to look at work, education, health, and relationship functioning among these veterans. Prevalence of moral injury. So about 1/3 report witnessing something while they were deployed that continues to bother them. And then roughly 15% report exposure either by perpetration, either through commission or omission. Interestingly here is that more women than men tend to report witnessing things that violate their values, but there is no evidence of a gender difference on either commission or omission. That is actually contrary to what we hypothesized, because most of these data were collected before women tended to participate in combat roles. Most of them had support roles, and we typically think of combat roles being more strongly associated with a likelihood of exposure to a potentially morally injurious event, especially involving use of violence, that kind of thing. Regarding the association between mental health variables and exposure to potentially morally injurious events, women who witnessed events that violated their values were much more likely to screen positive for PTSD, depression, and anxiety. Interestingly, even though women and men reported the same level of exposure to potentially to perpetration based, so either commission or omission, doing something that violated your values or failing to do something, among women, there was no evidence of association between perpetration and mental health problems. That's different than we observed among men. So among men, perpetration and to a lesser extent witnessing was associated with greater odds of screening positive for PTSD, depression, and anxiety. In addition to the mental health outcomes, we also looked at psychosocial functioning. We know that mental health and psychosocial functioning are related, but there's also evidence to suggest that they're not completely overlapping and that it's important to study functioning in its own right. And among veteran women exposed to a PMIE, those who reported transgressing their values by perpetration had greater odds of reporting impaired financial security, impaired health behavior, and impaired intimate relationship functioning. Those who had witnessed something that violated their values had greater odds of impaired health behavior. Among veteran men, those who reported transgressing their values by commission or omission had greater odds of problems at work, lower academic performance, poor financial security, impaired health behavior, poor relationship functioning, and I see this one in my clinic a lot, poor parental functioning, and disengagement from the community. Interestingly, there was no evidence of a functional impairment attributed to witnessing among men. So now that we know that moral injury or exposure to potentially morally injurious events is associated with mental health problems and functional impairment, we wanted to take it a step further and see if within that gap of the first 3 years when a person returns from deployment and separates from military service, if they were more likely to engage in suicidal behavior, specifically suicide attempts. So this is a really important window in time because veterans within that first 3 years after separating from service are least likely in their lifetime to be connected to VA services and most likely to attempt suicide. So sometimes we call this the deadly gap. And the more we can understand about psychological and functional problems, reintegration difficulties that our veterans are having, during this period, the better we can tailor our interventions to prevent veteran suicide. So the data I'll be sharing with you today are coming from a parent study referred to the Comparative Health Assessment Interview and Research Study, or CHI study. This is quarterbacked by Dr. Aaron Schneiderman at the VA Epidemiology Program and a number of other vet investigators who are acknowledged here on the slide. But Dr. McGinn and I led the attempt here to explore moral injuries prevalence and relationship with suicide attempt. So participants in this study were 15,166 veterans who had an active period of service between September 2001 and May 2015, and then had separated and been assessed sometime between April to August of 2018. Again, this sample is weighted to adjust to the entire population of OIF, OEF, OND community dwelling veterans. So those are our post 9/11 veteran era. The measures included the Columbia CSSRS for measuring suicide attempt, and we actually examined attempt and ideation before military, during military, and after separation. We included the most widely used measure of moral injury, and then a variety of measures that are often included to assess common post-deployment mental health problems, including PTSD, depression, anxiety, alcohol use, military sex trauma or MST, and adverse childhood events. So I'm going to present to you some gender stratified logistic regressions with suicide attempt as the dependent variables and a variety. It's really a kitchen sink approach in the independent variables. But in prevalence, this looks very similar to what we learned from the TVMI study. So again, about 1 in 3 veteran men and women, 1 in 3 veteran women reporting exposure to a PMIE by witnessing 1 in 4 veteran men. And that is a significant gender difference there again. And then about 15% of both men and women reporting exposure to a PMIE by commission or omission. No gender difference on those perpetration-based exposures. And here are the results of the regression. So it's kind of a lot to look at in this table, but you can see along the columns there, we have the gender stratified men and women. And then underneath each are peri-military. So if a person reported an attempt to kill themselves during their period of military service, as well as post-military or reporting an attempt to kill themselves after separating from service, and then that for women as well. Along the independent variables, we did this in a set of 3 different blocks, but you can see here that we really wanted a rigorous test for the association between moral injury and suicide attempt. And so in order to get that rigorous test, we threw everything we had to explain the variance in suicide attempt, and then let moral injury explain the additional variance. So this includes age, racial minority status, marital status, parental status, sexual minority status, highest level of education, branch of service, rank, whether they were deployed to a war zone, had a history of MST, the number of adverse childhood events they were exposed to, current PTSD diagnosis, current depression diagnosis, current anxiety diagnosis, current alcohol use disorder diagnosis, if they endorsed having a pre-military suicide attempt or ideation. So we threw all of that to explain who attempted suicide during or after their military service, and then let the moral injury explain the variance. As you can see, they're highlighted in the box at the bottom. Those who reported perpetrating their values or perpetrating a transgression that violated their values were 50%, roughly 50% more likely to attempt suicide during service, and nearly twice as likely to attempt suicide after service. I think a really interesting comparison here is that PTSD diagnosis was actually only significantly related to suicide attempts during their military service, but it dropped to non-significance in the post-after separation. And so what I'm seeing in that is that the impact of being in a highly threatening environment on the likelihood of a person's suicide attempt is decreasing the further they get away from that, right? So they encountered a lot of life-threatening situations in the military, and sometimes suicide attempt can be seen as a relief to get away from that. But as soon as they're out, we do see some attenuation in the strength of the relationship between PTSD and suicide attempt, but not so with moral injury. There was actually an increase in the strength of the association after separation. And this makes a lot of sense to me as a clinician, especially when I think about the developmental milestones that people start to experience when they separate service, like having their own kids, getting a romantic partner, and they start reflecting on things like being involved in harm to a vulnerable child or civilian while they were deployed. Among women, we saw that PTSD remained a strong predictor both during and after military service. Also, we saw a stronger effect for military sex trauma among women, and we know from other population-based studies that women are about 20 times more likely to report sexual harassment or assault than are veteran men. And that there is a considerable impact here of feeling institutional betrayal by women in terms of prediction of suicide attempt during and after service. So in summary of what we've seen in these recent veteran studies, 1 in 3 community dwelling veterans is endorsing exposure to a PMIE by witnessing, 15% by perpetrating. And these are community dwelling veterans, not people that are looking for treatment from a hospital or showing up in our clinics for those of us in clinical practice. I expect that the rates would be considerably higher in those that are mental health treatment seeking, and have seen some, in much smaller samples, seen some evidence to suggest that exposure can be as much as 50% among veteran treatment seeking samples. Also, we know that moral injury is associated with psychiatric and functional problems, including suicide in veterans from these studies. And we know that moral injury accounts for variance in who experiences psychiatric and functional problems beyond the impact of common post-deployment mental health issues, including PTSD and depression. So now I'd like to transition us to some work that has actually come out of a partnership here at the Lyda Hill Institute for Human Resilience. So this is a collaboration between Andrew Smith and Chip Benight and myself, who are on the call today. But it is going to be a set of 2 studies where we looked at exposure to moral injury and its impact on mental health and burnout among frontline personnel affected by COVID-19. So we have a review paper that's also out there under review, trying to figure out what kind of pandemic-related events could be potentially morally injurious for our public health workforce. And I think we've got a really interesting and ecologically valid lineup here of events. So failing to prevent or being the cause of an infection to a vulnerable person, whether that's someone like an immunocompromised patient, or if you have a household member who's an immunocompromised. Also restricting access to essential testing or treatment resources due to lack of supply. So this is like the ventilator problem that we talked about earlier. Perhaps enforcing safety precautions or restrictions that may do collateral harm. So we know that, for example, nurses who have had to deny family members of dying patients from coming in to see their family member as they passed report a considerable amount of emotional distress that does seem to mimic some of the the outcomes of moral injury in veterans. Witnessing racial or economic disparities in testing, care, and survival rates of infected persons, and failing to offer timely and vital intervention due to the effects of the crisis. So this might be if those of us who work in mental health clinics, if you have a patient who is suicidal and could use a higher level of care, but also is anxious about COVID precautions that are happening in an inpatient unit, and you choose to monitor on an outpatient basis and a lower level of care, and the individual completes suicide. Also, we've seen epidemics of domestic violence, child abuse that have kind of been secondary to the COVID-19 pandemic. And in those situations, many mental health providers who feel like, because of the resources on which they would typically rely to address these issues aren't available due to the pandemic, that they can feel like they didn't do enough in a really impossible situation. I think an important caveat to remember that comes from Brett Litz and Patricia Carrig from the special issue that they did on moral injury in the Journal of Traumatic Stress is that, especially among those of us who practice clinically, we know that ethical challenges are part of the job. We're trained for this and encounter it on a daily basis. And so it can be helpful to think about potentially morally injurious events on continua of frequency and intensity. So we often encounter events that are high frequency, but not a whole lot of intensity. And I often give an example of this, like I'm a person who loves the environment. I don't like it when I go to a restaurant and they give me a plastic straw, but it doesn't cause me a moral injury. On the other hand, we have much more rare events that occur and are typically associated with more a greater level of distress. And that's something that we have heard from a lot of the healthcare providers currently who have said that they were never anticipated dealing with something like the level of patient acuity and patient volume that they're currently dealing with and having to make decisions about withholding treatment, that kind of thing. So back to this study that's coming out of the project quarterbacked by Andrew Smith and on which there's several Lyda Hill Institute people as authors. But this is a first author paper by a student who was working with us here at Arkansas, Dr. Anandi Amen now. But we are going to walk through some of the findings from these two samples of emergency personnel and healthcare workers. So the emergency personnel was 473 respondents. Most of them were male, mean age about 42. It was administered in the Rocky Mountain, US. The survey was administered in Rocky Mountain, US between March and May of 2020. And we gave them a measure of moral injury, also mental health outcomes, including anxiety, depression, traumatic stress, and a functional impairment measure to assess burnout. And our analytic plan was a regression-based approach to testing moderation. So for those of you who are familiar with the Preacher and Hayes approach, that's what Dr. Amen utilized. Mental health screening prevalence at that time, March to May 2020, roughly between 15 and 20% of the first responders that we surveyed screened positive for traumatic stress, anxiety, or depression. Interestingly, there were pretty high rates of burnout as well. You can see there folks reporting limited ability to feel compassionate, being mentally and physically exhausted, and losing the sense of accomplishment in their work. Moral injury screening prevalence. So before the pandemic, there was not a measure out there that was appropriate for assessing moral injury in non-military populations. So we really deployed this one fast. It was a lot of work, especially done by Andrew Smith, but we deployed it at the outset of the pandemic and came up with these two questions to assess moral injury based on the continua that I showed you a minute ago from the Litz and Carrig article. But the questions to assess frequency of exposure was how often have you encountered ethically or morally difficult situations at work involving individuals potentially infected with COVID-19? And then to assess intensity, how bothered were you by these morally or ethically challenging situations at work? 21% reported exposure sometimes or often. 17% reported moderate to extreme sense of subjective distress coming from it. Here are the results of the moderation. So you can see on the x-axis is frequency, with toward the left being low frequency, to the right being high frequency. On the y-axis is the GAD-7 score. So this is just reported for anxiety here. And then the two lines, the dotted line represents those who were reported a low intensity exposure, and the solid line is those who reported a high intensity exposure, and this is a significant interaction. So what you can see with the simple slopes posted there on the graph is that for those that reported low intensity exposure, frequency of exposure did not have an impact on anxiety related distress. However, the story was different among those who reported high intensity exposure. If you were more frequently exposed to more intense PMIES, then you reported higher levels of anxiety. Just to show that that wasn't a one-off that we found, we observed the interaction among depression scores and PTSD or traumatic stress scores there as well. The interaction didn't hold up in the burnout scale yet. And so I'm kind of curious about why that might be, and would be interested if you guys have any thoughts. Moving on to study 2, this is 854 hospital workers, interestingly 82% female. So this is one of the biggest samples that we have out there on a largely female sample to assess moral injury. They were 92% white, non-Hispanic, about 40 years of age. The survey was also administered between May and June 2020 in the Rocky Mountain, US. They completed the same measures, and we conducted the same analyses that I previously described to you. Minorities of the sample that endorsed a clinically significant amount of mental health distress. It's 30% traumatic stress, roughly 30% anxiety, and about 20% depression. Burnout rates were even higher in this sample. So somewhere between 25 and 50% reporting burnout, depending on what aspect of burnout that you're looking at. Rates of screening prevalence, so about 20 to 30% reported exposure, 20%, more like 25% reporting exposure to a PMIE on a sometimes or often basis. And in terms of being bothered, 29% endorsed feeling moderately or extremely bothered. I think a really interesting finding that fell out of this was that there are more that are reporting being bothered than are reporting frequent exposure. So among these healthcare workers, even a one-off, if it is distressing enough, it's causing them a current level of distress that is remarkable to them. And here's the conditional effect. So you can see there, again, with frequency on the x-axis and anxiety score on the y-axis, dotted line is low intensity exposure to a PMIE, solid line is a high intensity exposure. Those who were exposed to more intense PMIEs, even on an infrequent basis, had high anxiety. So there's a main effect of intensity here, but the simple slope there is non-significant, showing that there was no increase in anxiety with frequency of exposure. I think one thing that's super interesting for this group is this next finding. So to my knowledge, there is very little, if not nothing, out there on resilience and moral injury. And what we observed here is an inoculation effect. So you have, for those exposed to low intensity PMIEs on a more frequent basis, their anxiety went down. So that is one of the first pieces of evidence of a protective effect that was naturally occurring here, but has really interesting implications for how we move forward with something like prevention of moral injury by incorporating more ethics training to match the technical training that folks receive. So just a summary, frontline personnel who are exposed to PMIEs while on the job, or they are exposed while on the job, especially during crises like the COVID-19 pandemic. Like veterans, they report, folks who are exposed to PMIEs are more likely to report adverse mental health and outcomes and functional deficits. And that comment about this is some of the first evidence in the moral injury literature of a protective effect that comes with additional exposure to low intensity ethical challenges. So moving on to the research agenda, like any nascent literature, there are so many directions to go. Like we could do a whole nother seminar on that, but I've identified 3 big areas that I think stand out to me. One is psychometric development. So that measure that I've been talking to you about is the most widely used measure of moral injury. It's the first measure of moral injury, and I'm excited that we have it, but it is not a perfect measure. And one issue with it is that some of the items conflate exposure to events with actual outcomes. It would be as if you were conflating combat exposure with PTSD outcomes. So we need to do some additional psychometric work there. We also need to do some psychometric work to move the measures that we have for moral injury to also be appropriate for non-military related populations. And that leads me to talking about specialized samples. So the COVID-19 pandemic has been a huge catalyst in the moral injury literature, and there's a lot of interest now in studying healthcare workers, first responders, and then particularly kind of subgroups that I think will be important to examine, especially as we move to this next wave of moral injury research. We have a prevalence now overall, but examining differences that happen, especially among subgroups like women veterans or veterans who are people of color, are going to be important to consider. And then finally, treatment and prevention. There are a number of great treatments that are emerging evidence-based moral injury treatments that are out there: Building Spiritual Strength, Impact of Killing. MC3 is a mental health clinician clergy collaboration project, Adaptive Disclosure. All of these are starting to build evidence to show that they are effective. But we do need to look at some additional outcomes. For example, most have just looked at stress-related symptoms. And also most have only done a single arm comparison or had a treatment as usual comparison. And I think especially because VA has gold standard treatments around EBP for PTSD, it would be very interesting to start to pair moral injury treatments with EBPs for PTSD and do some comparative effectiveness work. But I really want to talk to you more about forgiveness, because forgiveness is where I cut my teeth on all this research stuff, working with Ev Worthington at Virginia Commonwealth University, and particularly in self-forgiveness. So from my work with Ev, we developed the dual process model of self-forgiveness. And we did that to suggest that self-forgiveness is not just letting yourself off the proverbial hook, that it must include accepting an accurate level of responsibility, and being willing to make amends for perceived transgression, while also accepting yourself as a flawed but valuable person. Much of the information about this model and the work Ev and I have done together, as well as the work of a number of other leaders in this field, including Lydia Woodyat, Marilyn Cornish, and several others, is included in the handbook on the psychology of self-forgiveness that Lydia, Ev, Michael, and I published a few years back. An interesting way to use this model is to compare self-forgiveness to other ways of coping with wrongdoing. So you can think of when your reorientation toward positive values is high. So this is that accepting personal responsibility, being willing to make amends is high, and also the restoration of personal esteem is high, then what you get is self-forgiveness. But if you're missing either of those, what you get is not self-forgiveness. So if I'm really motivated to repair my wrongdoing and do it by denigrating myself, that's self-punishment. Or if I can build myself up, but really don't give a care for the consequences of my wrongdoing, especially on other people, then I'm just exonerating myself. And we have done some interesting mixture modeling work among South Africans through some of the data collection efforts of Richard Cowden, who's now working at Harvard on some of these issues. But we have seen some really interesting evidence to see those three coping responses in particular holding up. We're still kind of looking for the self-inhibition. But we use this model that I'm described to you to develop a low-intensity, high-reach intervention for university, and we tested it in university students as part of my master's thesis several years ago. So these are 102 university students randomly assigned to immediate treatment or waitlist control. They completed a measure of self-forgiveness as also measures of guilt and shame, rumination, satisfaction with life. So a lot of these are the mental health correlates that have been connected to self-forgiveness. The design was an immediate or a waitlist controlled design. So you can see there that at baseline, we assessed both of the randomly assigned groups, and then between the first and second assessment occasion, those assigned to immediate treatment completed the workbook. And then between the second and third assessment occasion, they just went about their lives as usual. And that is in contrast to the waitlist condition, who just went about their lives as usual between the first and second occasions, but then completed the treatment between the second and third occasions. The distance between these occasions were 4 weeks. And this is just a little bit of information about the workbook in the form that the university students received. Things about identifying what is self-forgiveness and what isn't self-forgiveness. Coming up with how do we make meaning out of guilt and shame. For example, these self-conscious emotions can motivate amends-making behavior, but when we perceive that it's impossible to make amends, that oftentimes they can become chronic sources of stress. Elements of a good confession, dealing with perfectionistic standards. You can kind of get a sense of the clinical content there. Here's the interaction that we observed for the self-forgiveness scale. So this is on the x-axis time, y-axis is self-forgiveness score, and the solid line are those in immediate treatment, the dotted line are those in the waitlist control. And as far as the mathematicians go, this is beautiful because we got that cross-level interaction effect, an increase in self-forgiveness for the immediate treatment group when they were completing treatment, and then they maintained those gains, whereas the waitlist control group stayed right in the pocket. And as soon as they completed the treatment here, they made similar gains as those before. Not only was this effect statistically significant, but Cohen's d was 0.37. So for getting someone to do a workbook that took them 6 hours to complete, a change that's around an effect size of 0.37 is pretty substantial, and we were excited to see that. I also broke out, I wanted to measure dose, and so I took the number of words that each student wrote in their workbook and put it into quartiles and examined the response to treatment based on the quartile. So quartile 1 will be those who wrote the fewest words, followed by 2, 3, and 4, those who wrote the most words. And we found that this was in fact statistically significant, and that the more words you wrote in the workbook, the more you got out of it. So there's evidence of a dose response effect there. So conclusions from this: we can use a manual to promote self-forgiveness and its benefits for mental health. Also, we need some strategies to increase dose and adherence to optimize effects. Some limitations are that it's a convenient sample of undergraduates. There could be some selection bias because it's hard to keep students in a self-directed treatment, and that I'd like to have an active control condition as opposed to the non-active waitlist for future studies. So I'd like to build off of this with a VA CDA grant that I currently have under review. So this is the VA equivalent of a K award, but the purpose of the grant is to adapt that workbook that we developed with university students to address moral injury in veterans. So we will adapt it based on an iterative process of getting feedback from veterans and providers, including mental health and chaplain. We are going to conduct a hybrid effectiveness implementation trial to pilot the recovery manual for moral injury, is what we're calling it, so REMI. And then we're going to test the extent to which the association between moral injury and poor mental health outcomes holds up among veterans, specifically in terms of the effect of self-forgiveness. So there's a big meta-analysis out there connecting self-forgiveness to decrease depression, anger, anxiety, suicide risk in civilians. And I want to see, does it hold up in veterans? In order to assess its efficacy, we have adapted the scale that I used to use with civilians in order to assess these two factors of self-forgiveness among veterans. And you can kind of see what I'm talking about when I say value reorientation, with responsibility taking, also esteem restoration, so having compassion for yourself. And that's the end of the talk. So I just wanted to acknowledge some of the people who've been very influential in this line of work for me, and open us up for some questions.
Thank you, Brandon, very much. I love that talk and would be very interested to see if we could get some questions. I've got some, but I want to open it up to the group because we have quite a few people online with us. So questions for Brandon, please. Okay, I'll start. All you shy people out there. So Brandon, I'm curious about a couple things. One is thinking about moral disengagement theory and Bandura's work, and wondering how that interplays with with moral disengagement theory. So thinking about how when people develop these strategies for moral disengagement as a way of coping, as a way of doing whatever it is that they have to do, especially in the context of the military and healthcare workers. One question would be, do you think they are doing moral disengagement type of approaches where they're distancing from the act and in some cases blaming the victim in different ways? Not that these people who are trying to do the best they can do in the situations, but wondering about that intersection of the moral disengagement theory piece. Have you thought about that?
I have. So Bandura's moral disengagement theory was really influential in the development of that dual process self-forgiveness model because of its underpinnings around belonging being facilitated by responsibility and esteem being facilitated by kind of having compassion toward yourself. In the work with veterans, I see it at play, especially regarding the dynamics involved with separating from service. So I showed you that connection between moral injury, perpetration-based moral injury, and suicide attempt becoming increasingly stronger when people separate from service.
Right.
I think when you are connected to command and have your unit around you, it's easier to displace personal responsibility to them. But after you separate and you're on your own, it starts to feel like you have a greater burden of personal responsibility associated with that transgression. So some of those disengagement strategies, like I was just doing my job, or I wasn't the only one doing this, we were all kind of involved in it. Some of those begin to become less effective after separation from service. So I think there's a lot of opportunity to expand on moral disengagement theory, and also Jonathan Haidt's moral foundations theory, thinking about care and love, loyalty. Like these are the kinds of things that I see in veterans, that when you disengage values, what you're really doing is prioritizing one or the other. And for example, when a child with a weapon approaches the checkpoint and you choose to fire, you're choosing loyalty over protecting your fellow service members and your duty to country over care for a vulnerable child who's been given, taken advantage of and given a weapon. So I think there's a lot to do here with moral disengagement.
Interesting. Thank you very much.
Brandon, I'm curious about, great talk, really such a young construct and such an important one right now, I think. I'm curious about how you think this is playing out in veterans thinking about the Afghanistan debacle that's currently going on.
Yeah, I think that's an incredibly relevant concern. I can say from my own clinical practice that seeing images of Afghan locals falling off American Air Force planes have been very triggering, especially for those whose PMIE is associated with care for a vulnerable civilian, like Afghani civilian. So I've been doing a lot of booster sessions the past week or so to process what's coming out with that. And I think it will be also interesting to see how the prevalence changes in terms of when people are reflecting on their service and its meaningfulness. We know meaning making is one of the most useful strategies to deal with trauma, and and that extends to moral injury. And I think that many of our veterans right now are having trouble making meaning of their service when they see what's happening.
I can see it playing out on both the omission-commission side related to relationship building, that veterans have done with civilian counterparts, as well as on the institutional betrayal side. So it's really an interesting set of concepts. It's kind of scary to see playing out in real time.
Yeah, I mean, atrocity has been with us as long as war has, so since ever. But I do think that moral injury is not going away. If we have talked a lot about PTSD being the signature injury of post 9/11 veterans, but I think moral injury is getting a pretty strong stake in the game, especially seeing the Afghanistan crisis, the COVID crisis. It's just rising to the top right now.
This is Joe. I just wanted to comment that the low intensity, high reach intervention, it would be great if there was a way to put a technology module on the My Trauma Recovery platform, because the platform will be very stable and it'll be maintained by the Institute. It'd be great to do that because we'd open up a whole different set of studies. So I know you're already thinking about that, but I just want to put in my own personal plug for everybody to consider that. The other thing is that, I think it makes so much sense to focus on interventions to deal with moral injury in veterans and other populations. But, you know, I'm somebody who's concerned with things like climate change. And there, what we need to do is we need to figure out if it is possible to prevent moral disengagement. So I'm not a big believer that we can actually do that, because all of the people that are, you know, selling tires for automobiles or on, you know, our advertising professionals selling stuff for the oil companies or for all these things they're all perpetuating and preventing action to, you know, deal with the major problems that are coming. So, you know, I'd encourage you to think about opening up a completely different line of research at some point, because you're nailing down moral injury, but to think about the other side, and that is how to increase sense of moral injury and prevent moral disengagement mechanisms, just as a different kind of pro-social thing.
I think that's a really astute observation. My thinking has been moving that direction the more I'm working in populations other than veterans, because before it was everyone was separated from the organization that they had belonged to, and I was trying to put together a puzzle that broke 10 years ago, you know. But especially with folks involved in the U.S.-Mexico border crisis, with the pandemic, a lot of it has shaped my thinking to see the other side of the coin of promoting more.
I think it would be very fundable, because I don't believe anyone's ever done it. I was reading Bandura's text that Chip was talking about. You know, he's recounting the mechanisms, and then he goes through all of the domains of business functioning in American life, one after another. But I don't even think he really said that much about how to dismantle moral engagements. That's my 2 cents. Good.
You could start by using the way that my mom's strategy for guilting me into coming home for holidays as a start for that intervention.
Yeah. Go to the natural pros.
I'm aware there's actually a point in the chat, which we should be looking at the chat too, but so Tim writes, do you see a parallel between the system and admin factors associated with burnout relative to the betrayal of an authority figure or institution and moral injury? How do we look at systemic prevention versus individual intervention after PMIES? And I totally echo that. I wrote down in my paper here 6 systems. I think we're right in the beginning right now of some very, and I say sick, not in the sense of you know, degrading or something, but just sick. They're overloaded, they're imploding. There's all kinds of issues that are happening right now with a lot of systems that we rely on and that individuals are a part of. So I agree with that question around the systemic prevention question and how do we manage that. I'm also aware that we're out of time. And Heather was going to say some stuff. Brooks, do you want to take over? I've got to jump on another call, unfortunately.
Yeah, I'm just going to pass it to Heather because we want to give some information out about next month.
Absolutely. Yeah. So I will just say that, you know, when Jonathan Shea wrote, as you know, wrote about moral injury, he talked about it starting at the institutional level, that it was betrayal of what's right by the institution that starts the process of moral injury. So a little shout out to Shea. But yes, what I want to talk about especially is, as Brooks mentioned, we will not have one of these meetings next month because on September 24th from 9 to 11:30, we'll be having our first virtual symposium. And that is will be chaired by me, and it's designed to coincide with the release of a special issue of Psychology of Violence on Global Perspectives on Sexual Violence, with the full title being Understanding the Experiences of Marginalized Populations and Elucidating the Role of Sociocultural Factors in Sexual Violence. So look for the link, the Zoom link for that to be coming next week. We also have a web page describing the titles of all the talks and the bios of our speakers. So for now, mark that on your calendar, and I hope to see a lot of you next month. Thanks.
Thank you guys so much for the opportunity to share with you.
Thanks so much, Brandon.
Thank you, Brandon. Great talk.
Yeah, great talk.
Especially for the Institute folks, and I see Nathaniel and Tim and several, Jessica, that are other colleagues that are interested in this area, I know.